So welcome everybody. For anyone who doesn't know me, I'm Zach Pemberton-Whiteley and I'm chair of the Acute Leukemia Advocates Network. Thank you for joining us at our first ever summit. We hoped that this would originally be in person, so it's a shame that we're all here online and not in the same room with the chance to share best practice and connect. But obviously everybody knows the reason for that. Hopefully that will be possible to happen at some point in the future. So welcome from me to everyone who's joining. Welcome to all of the attendees. Thank you in particular to all of the speakers who've agreed to join us today. We've got a really exciting agenda planned. Thank you to all of the sponsors who have made this possible. Thank you to the Allen Steering Committee for all of their hard work, and thank you in particular to Samantha, who is our network manager, who has been responsible for all the work in putting this summit together. So really without her, this would not have been possible. For anyone who doesn't know about the Acute Leukemia Advocates Network, I'm just going to give a short introduction, and then I'm going to hand over to Samantha, who's going to talk through the work that Alan has been doing over the last year and the future direction of the network. So for anyone who doesn't know, Alan is a relatively new network. We've been going just over 3 years now. It's an independent network of patient organisations from around the world. And the aim is to improve outcomes of those living with acute leukemia, anyone affected. That includes patients, but also their families, by strengthening patient advocacy. Now, there are two main ways in which we aim to do this. The first one is building capacity. So through sharing best practice, connecting, providing tools for organisations to advocate better for patients in their countries at a national level. So one of those being, for example, the Global Summit, and that's the reason we're all here today. And then the second purpose of Alan as a network is to join forces and to look at projects and initiatives that only can be done by us working together at an international level. And that's really our second aim. So thank you very much. I'm going to hand over to Samantha, who's going to provide a background as to the work of what Alan has been doing over the last few months.
So hello everyone, good morning for pretty much everyone, maybe good evening for some of you. So yeah, I'm going to give you a quick update on what we are doing at the moment. Can you go to next slide, please? Okay, so all the activities that the network is running are patient-led initiatives. They are collaborative and they are evidence-based activities. Next slide. And so that's basically what I'm just going to go through in a minute. And if you go to the next slide. So we are running a series of initiatives, and also beside running all those projects, we are also involved in other initiatives that are initiated by other network or organizations. So I'm not going to go through all of them just now, but if you want more information, everything is on our website, or at any point, if you need even more information, then just feel free to email us and we will provide you with those information. Next. So obviously the first initiative I'm going to speak about is why we are here today. So it's, as Zach was mentioning before, it's the first ever Acute Leukemia Summit. As he also mentioned, the plan was to have this summit as a face-to-face, start engaging with people, start to know each other. And for the reasons we know, it's not possible this year. But the idea behind such event is to develop members as patient advocates, is to encourage individual who has an interest in acute leukemia to become advocates. So we are aiming to provide some education via medical sessions and also advocacy session. And it's probably not going to be so feasible today, but probably in the next face-to-face, it's also to exchange ideas, interact, and share some best practices, and to really create a network to bring people on an international level. it might not be so obvious, but that's actually a lot of work to be done. As Zach was mentioning, the network has been created in 2017, which is still fairly new, and we have to make the network more visible. So really grow the social media presence, make sure the website is used as a reference website, make sure that people are talking about the Acute Leukemia Advocates Network, and also growing the network. So I think we have almost double numbers of member organizations in the last 6 to 8 months. So now we have 40 members from 35 countries, and that's still growing. And again, that might not be might not seem like a lot of work, but that's actually a lot of work to do to actually grow the presence. And next slide. Some of you are already very familiar with this project. So Alan have been running a survey. The survey is actually closed now. It was actually run last year. It was a multi-country survey. Some of you have been involved in the design of it, and some of you have been helping us to actually share. And it's really about creating evidence about the quality of life of acute leukemia patients. And with the results, we are hopefully going to create some support education, some information tool to help physicians, but also to help patients and caregivers. If you go to next slide. We have had already some posters presented in the major hematology congresses. So last year at ASH, this year at EHA. Zach was also involved in the EHA working group on quality of life. And we also have been submitting an abstract for ASH this year. Hopefully it's going to be accepted. And we are also working now towards a publication in a scientific journal. One of the other activities we are doing is to run a series of webinars. We have had already 2 this year. The first one was run in April, coinciding with the AML Worldwide Day. And we had another one beginning of September. It was a joint webinar with Cher for Rare on the patient advocate conducting research in oncology. We are going to have other webinars in 2020, and this will be advertised on the website as well as on social media, and probably by email as well. And it's open to everyone. It's always free, so feel free to join when you see that online. The other thing we are actually running is a capacity building program called Advocates Development Program. It's going to be a 1-year program. It's probably going to be fully virtual at this point for the reasons we know. It's really to develop advocates to become more effective and more efficient. So it's going to be a mix of sessions to be attended virtually with a bit of homework to be done. And it's really to build some advocacy capacity with the members. So we are going to actually start the application process in the next days with a first virtual meeting planned for this early December 2020. Yeah, that's it. And we have been also very busy to develop the awareness campaign. You may have seen a lot of things going on social media, especially for the Blood Cancer Awareness Month, which still is in September. So the idea behind was to raise some awareness about leukemia/acute leukemia regarding the symptoms with the focus on early diagnosis. It was a joint initiative with the CLL Advocate Network, the CML Advocate Network, and Leukemia Care. So you may have seen via social media the World Leukemia Day hashtag, the Be Leukemia Well hashtag. A series of materials have been created, so you still can access those materials and you can still use those materials. Everything is free. You can use, you can translate, you can reshare. It's open to everyone. You have the link to the website. And then if you go to the next slide, and just to mention that the campaign has been a big success, and that's only the numbers. Well, that's some of the numbers only for the Acute Leukemia Advocate Network. If you look at the Facebook page and if you see the peak on each of the small picture, that's actually all the activity that's been taking place on the 4th of September. We have been gaining a lot of followers, and most importantly, just via Twitter with all the work being done, we have reached over 10 million people. So I think we can definitely say that this was a big success, and all the internet community has been speaking about leukemia on 4th of September. Yeah, and I think that's it for me. If there are any questions.
So we've got a few questions coming through from the chat. Apologies, I forgot to say at the beginning. If people have questions, please post them in the chat. But we had a few coming through already, so I'll ask those. So an easy one to start off with, Samantha. If people want to apply for the Advocacy Development Programme, if any of the members want to join, how do they find out more and where do they apply?
So the information is already on the website in the ADP section. I'm going also to create a news on the website with the application form. And otherwise, we are going to send emails to our members with the application form as well.
And another question around the survey. Next steps for the survey, when do we expect further outputs, including publications and educational materials, to be available?
So we expect publication by the end of this year, if everything goes well. And probably educational material is going to be something which is going to keep us busy next year, 2021.
Excellent, thank you. Do we have any more questions coming through in the chat, if anyone has anything they want to know? No, excellent. Well, thank you very much, Samantha, for that wonderful presentation and for giving all that information as to the work that Alan's been doing. I'm going to pass over now to start our medical session slightly early. We're pleased to be joined by Esther Oliva, who's going to be presenting first around the hot topics in AML. If anyone has any questions whilst she's presenting, please do post them in the chat and there'll be the opportunity to ask all of these questions at the end. So thank you. Over to Esther.
Okay, thank you very much to Alan and to Zach and Samantha in particular for this invitation. And I will be talking about hot topics and latest advances in acute myeloid leukemia. And I did have to struggle through eliminating so many scientific graphs that are so complicated to understand for patients and people that are not normally in the medical system. So here we go, and I hope you can have lots of questions coming in case something is not clear. Next slide. So acute myeloid leukemia is a clonal malignant disease of myeloid cells, bone marrow cells, and it is a rare disease. It is more commonly diagnosed in developed countries, so we don't have a perfect estimate of the incidence rate in the world. However, the incidence rate in Europe is about 3.6 per 100,000. 25%, it represents 25% of all of the leukemias in adults, and it primarily affects adults and children less than 1 year. In fact, it generally, the risk increases with age, and it's most common in people over 65 years of age, which we will now call elderly. Please, next slide. So I do show this graph where you can see the increase in the incidence, the annual incidence rate per 100,000 people. And you can see how the incidence increases by age, so that you can have a high incidence rate over 75 years of age, and it is prevalent in male gender. Next slide. So it rarely presents without symptoms, and it just might come across through a routine blood test. Generally, patients present with symptoms that could go from loss of appetite or weight loss, mild fever, and then of course symptoms and signs of altered blood cells. So reduced red blood cells will be called anemia, and it will cause fatigue, shortness of breath on exertion, and other anemia-related symptoms. The reduction of platelets, called thrombocytopenia, will be responsible for bleeding. So easy bruising, blood spots on the body, which are called petechiae, bleeding in the nose or from the gums, prolonged bleeding from minor cuts. And then white blood cells, importantly the neutrophil count, will cause leukopenia, or for the neutrophils, it's called neutropenia, and it's responsible for recurrent minor infections or poor healing. And in some patients, they will come into hospital at onset of leukemia with pneumonia. Next slide. There are some predisposing factors that have been identified. One is an antecedent blood disorder, for instance, myelodysplastic syndromes, or other myeloid malignancies like chronic myeloid leukemia, polycythemia vera, essential thrombocythemia, and myelofibrosis. Then there are two rare diseases. One is paroxysmal nocturnal hemoglobinuria. The other is aplastic anemia, and they rarely evolve to acute myeloid leukemia. Then there are some environmental factors, radiotherapy, drugs, chemotherapeutic drugs, so having cancer prior to leukemia and having received chemotherapy. And then there are some genetic diseases like Down syndrome that can predispose to acute myeloid leukemia. Next slide. So we can generally say that we can diagnose a primary or de novo acute myeloid leukemia when you don't find a predisposing factor, or secondary acute myeloid leukemia, meaning secondary to previous therapy or to a previous hematological disease. Next slide. And then physicians will have to tackle through the World Health Organization classification, which has now become so complex and includes genetic findings in the bone marrow. So you can have acute myeloid leukemias with specific genetic alterations. So this shows the importance of performing genetics for AML patients. Then we distinguish AML with myelodysplastic related changes, sometimes coming through from a myelodysplastic syndrome, even though not previously diagnosed. Therapy related myeloid neoplasms. Next slide. And for those that do not have, or that are not classified as in the previous slide, we call them AML not otherwise specified. And the microscope will help in diagnosing the different types. And then we have some rare acute myeloid leukemia types like myeloid sarcoma and those associated with Down syndrome, etc. Next slide. So once a diagnosis is made, physicians and patients would like to know about prognosis. First of all, age is a prognostic factor, so that young patients have a much better prognosis, and as years advance, the prognosis becomes quite poor. And then having a secondary acute myeloid leukemia, again, I'll remind you it's secondary to treatment, secondary to other malignant disorders, has a poorer prognosis and a high number of white blood cells at presentation, or rarely the involvement of the central nervous system would give a poorer prognosis. And then, of course, the response to treatment is prognostic. If a responder will have a better probability of surviving compared to those that do not. And then cytogenetics have a very important role in conferring prognosis and sometimes helps in choosing treatment for patients. So this should be obtained when possible at the time of diagnosis. Next slide. So being elderly means already having a poor prognostic factor. Generally, elderly patients cannot tolerate chemotherapy or even more bone marrow transplantation, and it's due to a different disease biology. These patients have a different cytogenetic bone marrow profile, and more frequently they will present with a prior hematological disorder such as myelodysplastic syndromes. Next slide. And here you can see that it's a bit complex, but here you can see the difference in cytogenetics between younger and older age. Please go forward. And here you will see the good cytogenetics in younger patients compared to a less frequent proportion in the elderly patients. So more frequently, elderly patients have poor cytogenetics, which confer a poorer prognosis. Next slide. And then we need to evaluate genetic prognostic markers, and we have a very simple panel on the left that should normally be done in any clinic because it confers not only prognosis, but today also helps in choosing treatment. And lately, there is a discovery of at least 236 genes, but many more are being discovered every day in research laboratories. Next. So importantly, diagnosis and prognosis should be done in the clinics, starting with a simple peripheral blood count, peripheral blood morphology at the microscope, bone marrow morphology, multi-parameter flow cytometry in the lab, cytogenetics, if possible, within the first 10 days. And then genetic profiling. We need the simple panel and an extended panel to be able to evaluate patients for further treatment and for prognosis itself. Next. How does acute myeloid leukemia cause illness? It causes illness because it causes a deficiency in the normal blood cell number or function by replacing normal cells with malignant cells, so they're crowded out. A direct growth inhibition sends signals not to grow. Invasion also of vital organs, so finally an impairment of organ function, and some systemic disturbances by metabolic imbalance, because leukemic cells can also secrete disturbing metabolic substances. And then cytotoxic chemotherapy is also associated with morbidity, and so it's sometimes very difficult to distinguish between treatment side effects and disease effects. Next. So the deficiency in normal blood cells will give consequences. We said that they would give symptoms, but the complication results in infection when the white blood cells or neutrophil count is low, hemorrhage due to abnormal platelet counts, but you can also have, as a severe consequence, a disseminated intravascular coagulation due to consumption of blood clotting factors in the blood. And then anemia due to reduced red cell count. Of course, for hemorrhage and anemia, we can give transfusions of platelets and transfusions of red blood cells. For infection, we need to use some growth factors when they do function, and also broad spectrum antibiotics and antifungal agents. Next. So the current treatment, well, you know, surprisingly, we're still using treatments that have been around for the last 50 years. And this is induction chemotherapy, which I will continue calling IC. And this is offered for fit patients. And the rationale is to quickly get rid of as many leukemia cells as possible. The treatment intensity will depend on the fitness of patients and age. And so that most patients will receive intensive therapy if they're younger than 60 years old, but some older fit patients can benefit from such treatment. And so the mainstay is still what we call 7+3. It's 7 days of cytarabine or Ara-C and 3 days of an anthracycline. Next. So the aim is to induce what we will now call CR, complete remission, meaning reduction of the leukemic cells in the bone marrow less than 5%, and improvements, almost normalization of peripheral blood counts, so resolution of anemia, leukemia, and thrombocytopenia. And the complete remission, the probability of complete remission is much higher in younger patients. And at increasing age, the remission rate will be reduced. And complete remission, though obtained in elderly patients, may not last as long as it would last in younger patients. Next slide. So there are some predictors of poor response to chemotherapy. First of all, unfit patients, elderly patients, unfavorable cytogenetic profile, a prior hematological disease, and unfavorable gene mutations. In particular, next slide. So we can consider good responders, patients with particular cytogenetics or gene mutations on the left, and poor responders, patients with bad cytogenetics, FLT3 mutation, secondary acute myeloid leukemia that could be treatment related or with myelodysplasia related changes. Next slide. So patients typically will need to be hospitalized during the 7+3 regimen. They get chemotherapy. On day 14, still in hospital. The goal is empty and less than 5% blasts. If blasts do remain, reinduction is usually appropriate. The recovery takes about 21 days. If the bone marrow is empty, it does not mean the patient has achieved remission. A complete remission is determined by morphology and by minimal residual disease, which could be flow cytometry or gene profiling. And this is quite important as it predicts relapse. Next. After remission, patients need to maintain remission. And as I said, the older patients tend to relapse more frequently than younger patients. However, for younger patients, they should receive chemotherapy, or for some patients at high risk of relapse, when possible, allogeneic stem cell transplantation. Next. Now, for those that cannot receive chemotherapy, we have been using hypomethylating agents in the past at least 10 years. And I believe it is these agents are available worldwide. And they are azacitidine and decitabine. They slow the production of leukemia cells and help the bone marrow produce more healthy and normal functioning cells, help increase blood cell counts by allowing the cells to grow in the bone marrow. And so they're not commonly given with the goal of cure, but can help patients survive longer. And this is an effective treatment also in older patients that have bad cytogenetics, seems to function quite well. And this is an important difference with conventional chemotherapy, in which patients do not respond well when they have adverse cytogenetics. And they do confer meaningful clinical activity, something that is meaningful for patients, transfusion independency, and improve survival, even if complete remission is not achieved. Next. And what about those patients that relapse or are refractory? There are quite a few drugs that have been approved, and I'm not sure they're so available worldwide yet, but for patients that have that bad FLT3 mutation, midostaurin is a target for FLT3 and can be useful in relapsed refractory patients. Then there is the CPX-351, which is available for those that have myelodysplastic related changes in treatment related acute myeloid leukemia. Then there is the IDH2 inhibitor, one of the genes that can be mutated in AML, and this is an oral drug, and it's available for refractory patients. There is gemtuzumab ozogamicin, which is an old drug that is reborn lately. It hits a target on the cell of the blast, specifically what we call CD33, which is on the membrane of the blast, and it's used for frontline treatment of acute myeloid leukemia. Ivosidenib, which is an IDH1 gene inhibitor, also an oral drug. Glasdegib, which is for frontline AML when chemotherapy is not indicated. Gilteritinib, FLT3 inhibitor. This is also oral agent. And very importantly, there is venetoclax, which is an oral drug indicated in combination with hypomethylating agents or low-dose cytarabine, which gives remission rates that are very high, surprisingly high, also in elderly patients, obtaining about a 60% remission rate compared to even 70%, and it's long-lasting. Next. So just to give you an idea of what is CPX-351, it is the 3+7 induction chemotherapy drug in a new formulation, which is better tolerated. It is a liposomal formulation. And the drug exposure is maintained even more than 7 days after the dose. And it is selectively taken up by the leukemia cells versus the normal cells, and it is given also in patients that have bad cytogenetics. Next. Now, my topic is future, so let's see what's happening around the world. So this is oral azacitidine, the hypomethylating agent. It's called CC486. And it has shown to be convenient as a maintenance therapy in patients receiving induction chemotherapy in first remission. And this was tested in patients that were not necessarily elderly, but over 55 years of age with de novo or even secondary AML that were in first remission with chemotherapy. Patients had even poor risk cytogenetics. They were ineligible for transplantation and had recovered bone marrow after chemotherapy. So they were given CC486 or placebo, and there was a significant advantage on overall and relapse rate. So it actually doubles the survival time, and it maintains quality of life stable in patients receiving treatment compared to placebo. So it is a very promising drug as maintenance treatment post-induction chemotherapy. Next. Gilteritinib. This is the FLT3 mutation drug associated with, so we know that FLT3 mutations is associated with high rates of relapse and poor survival, even after standard chemotherapy. It's a once daily oral tablet, and given in combination with induction chemotherapy, it seems to be safe. It has been shown that 3 tablets are safe per day, so 120 milligrams per day. Only 8% of patients discontinued treatment due to any side effects. And it has anti-leukemic activity in patients that have a diagnosis of FLT3 mutated acute myeloid leukemia with a poor prognosis. So given frontline with chemotherapy, can give complete remission rates of 94%. So it's quite promising as a drug to combine to induction chemotherapy. Next. So I told you that these IDH gene inhibitors have been approved for refractory patients with IDH mutations. Now, in patients with newly diagnosed AML, given with intensive chemotherapy for patients that harbor one of the 2 mutations, in patients that are also generally elderly, the complete remission rates increase. So we have 80% complete remission rate or 72% with these drugs. So these are promising in combination frontline for IDH mutated acute myeloid leukemia. Next slide. Now, also given with azacitidine, it confers an advantage on event-free survival of acute myeloid leukemia. So frontline, not with chemotherapy, but with azacitidine. Next slide. Also, ivosidenib plus azacitidine in newly diagnosed acute myeloid leukemia. The complete remission rates are higher than azacitidine alone, reaching 60%. Next. Now, azacitidine with venetoclax in treatment-naive patients with acute myeloid leukemia in standard induction therapy. The combination prolongs survival compared to azacitidine alone. So it is a very important combination and might represent the future of frontline treatment for any AML patient. Next. So here are the response rates by azacitidine and venetoclax frontline. There are more remissions, more transfusion independence, prolonged survival compared to azacitidine given with placebo in this clinical trial. Next. TP53 mutations, they are bad. And they are seen in about 5 to 10% of de novo AML and is present in about 40% of therapy-related AML and 50% of patients that have a complex cytogenetic profile. They confer short response to treatment, including intensive chemotherapy, hypomethylating agents, and a high risk of relapse after stem cell transplantation. Next. So there are some treatments being explored for TP53 as targeting TP53. Next slide. APR246 is one of these drugs. Go ahead, please. And it has given high response rates in AML patients. There are very few patients that have been reported. This was at the EHA, European Hematology Association, in June, and we're probably going to have updates, but it seems to be very promising in terms of responses, 78% or 100%, but those are only 2 patients. But in any case, seems quite promising. Next. But we do have important side effects, and one is neurological toxicity. It is fully reversible. But these are new drugs, and new drugs are giving new sorts of side effects that have to be recognized, and physicians have to learn how to deal with these side effects when, and also to choose patients appropriately considering the new side effects of new drugs. Next. There are lots of extracellular targets for AML treatment. Go ahead, please. There's MBG453. It is an antibody against TIM3, and it enhances the immune response of the patient to help kill AML cells. And it targets the immune system to work better, and it also targets leukemic cells and blasts. Next. This is the a very initial phase study using MBG plus hypomethylating agents, decitabine or azacitidine. Next slide. The response rate is 47% for decitabine, 29% for azacitidine. Next. Well tolerated, doesn't seem to give additional side effects than expected with the hypomethylating agent. So fever, reduced cell counts, and some other less common side effects, but common to the hypomethylating agents. Next. Then there is magrolimab, which is an it's an antibody against CD47, eliminates the tumor cells by inducing certain cells in the body to eat the leukemic cells, to destroy them. And it is being investigated in many cancers. Next. So patients with untreated AML that ineligible for induction chemotherapy were given the drug weekly, or in the next phase every 2 weeks, together with azacitidine. Next. And there was first-line acute myeloid leukemia, 64% overall response rate, so it's very promising. Next. We have also other antibodies being explored. Next. So what's happening in acute myeloid leukemia? We are, physicians and industry are looking for sensitivity to drugs that are specific for gene markers in the stem cells. We know that acute myeloid leukemia is so heterogeneous. There are thousands of possibilities of genotype drug interactions, even with a single drug. And so now we're moving forward to improve survival while taking care of quality of life of patients by doublet or even triple combinations to maximize the beneficial effects of treatment. Consider that 20 drugs can give about 190 doublet combinations and 1,140 triplet combinations, meaning there will be many clinical trials on their way to be offered to patients to evaluate which is the best combination. Next. So as of today, we have hypomethylator monotherapy, and we have low complete remission rates. We require several cycles to achieve best response, and we're not curing the acute myeloid leukemia. We have enasidenib used in an outpatient setting, may benefit older adults with de novo mutant IDH2 AML who are not candidates for chemotherapy. Ivosidenib, well tolerated. It is now being used in advanced IDH1 mutated refractory ML, induces transfusion independence, remissions, and in some patients also giving complete remissions. And then very, very exciting is the venetoclax plus hypomethylators. Tolerable safety, favorable complete remission rates in elderly patients with acute myeloid leukemia, with favorable responses in high-risk groups, even age 75 or older, poor cytogenetics, and even secondary acute myeloid leukemia. Next. So for refractory patients, because we have to consider that we do have refractory or relapse patients, there is a flow of thoughts of what we can give. And important is that we have some drugs on the market, but we should be offering clinical trials whenever possible. Next. So, treatment for acute myeloid leukemia will be ever more individualized. So for FLT3 mutated AML, we should incorporate a FLT3 inhibitor. Which one is the best? We don't know. We have some on the market and some new ones coming in. IDH1, IDH2 mutated acute myeloid leukemia. You can incorporate an inhibitor together with an hypomethylating agent. Venetoclax plus hypomethylating agent will be the standard of care. Maintenance therapy should also be required for patients obtaining a complete remission. Most probably it will be, for now, hypomethylating agent with or without another specific drug that will target a specific gene mutation or other marker. Significant number of promising agents are in development, so combination therapy may increase efficacy, and oral combinations, oral drugs, are warranted to improve quality of life to keep patients at home. So the future for acute myeloid leukemia treatment appears promising, but becomes very, very complex, both for physicians and for patients, because the choice will become, like I said, ever more individualized. Thank you. I'm open for questions. if they are possible to answer. I saw many questions coming in.
So thank you very much, Esther, for that very interesting overview. I think, as you say, it's becoming increasingly complex for clinicians and also for patients to understand. As you can imagine, we've got lots of questions. So let's start with the first one. The slides that you presented at the beginning around survival, how have we seen that changing with all of the new treatments coming through?
Okay, so the survival of induction chemotherapy has not changed. What is changing is probably the venetoclax hypomethylating agent. We are improving survival in elderly patients. And I think the target is the elderly population, and improving survival for those that are relapsed or refractory. Because we had to tackle with giving toxicity with chemotherapeutic drugs after relapse or in resistant patients, and losing them with side effects of chemotherapy and with progressive leukemia. Now we have more choice and more promise in treating relapse patients, and a much better survival and quality of life in elderly patients. You know, patients that were quite elderly, some weren't even offered treatment at all. They were given hydroxyurea and supportive care, transfusions. Today, I think that nobody would do without a hypomethylating agent. And today, combining, when possible, with venetoclax, or giving an IDH1 or IDH2 inhibitor can make a difference, and is making a difference in patients' survival time, but also quality of life.
Thank you. So again, you presented lots of different potential combinations. How are we going to work out over the next few years what the most promising combinations coming through appear to be?
Well, we rely on the trials, and I can say that the last EHA gave us a lot of confusion over what is best. Like, for instance, venetoclax works well even with IDH1 and IDH2 mutated patients, for instance. So at the end, what are we going to choose? It'll depend on many factors. Availability of the drug in a country, because as you know, here we are talking with many countries. And like I said, I know they have been approved, but some drugs are still not available everywhere. So the choice will depend upon the difference in outcomes that we will see with clinical trials that will compare. And we are also looking forward to triplets, maybe to confer complete remissions that may be responding to curing the AML. Because as we know, complete remissions doesn't mean curing the disease unless it lasts over 5 years. So we're at a moment in which it is difficult today for a physician to choose an appropriate treatment. You have to take into account the patient's individual status in life, caregivers, home care or not home care, the possibility of having a drug in the clinic, which one will give appropriate side effects that can be tolerated by patient, one drug versus another. So I think that it will be more difficult to choose, but we will have more satisfaction on results when combining or offering new treatments.
And where do you see the role of big data and novel clinical trials in this, in terms of determining which are the best combination approaches?
I think that the trial data will support the information on what to expect. So in terms of relapse and survival, and very importantly, any treatment emergent adverse events. The choice will then be made face-to-face, patient, caregivers, and family, and physicians.
So we've got some very specific questions coming through. So could you tell us more about the progress for TP53 patients, particularly around APR 246 and the slides you
Well, like I
presented
showed you, the patients that have been reported so far are too few, but the results are very promising. The neurotoxicity that it is associated with the treatment, so it's a treatment emergent adverse events, was concerning, but seems to be totally reversible. So if a patient does not have a neurological condition that is independent of the leukemia or the treatment, I think that it can be offered to patients with a TP53 mutation. There was some previous data on decitabine being particularly useful for TP53 mutations, but even decitabine will have a short-term efficacy for those patients. So that's why a specific inhibitor is needed, and to work out how to handle treatment emergent adverse events is very important, since the trial data seems so promising in terms of remissions. Then we still have to see how long the remissions will last. So the trial data is extremely important, but very promising.
So in terms of all of the new treatments coming through, have we seen any widespread side effects that we should be concerned about?
Well, the other drugs, not really. They don't have any particular side effects. In combination with a hypomethylating agent, it usually is comparable to the hypomethylating agent alone. So we have learned how to deal with it. And other side effects that are drug specific are very rare, or at least less than 10%. And physicians are instructed on how to handle the side effects so that patients do not have to leave treatment due to the side effects.
A question here relating to venetoclax. Do we know why combining venetoclax with so many different drugs seems to improve outcomes? There's a lot of research going on,
Yes,
really across hematology.
Yeah, it's a biological effect of enhancing the hypomethylators. So it's a synergistic effect at a biological level. So it's very complex, but it seems to be most promising right now with the hypomethylating agents, but in association with even an axitinib or ivosidenib, it seems to be an enhancer.
And with all of the new treatments coming through in AML, what's the role of ongoing bone marrow transplantation?
Well, for patients that have have a complete remission and are still eligible for bone marrow transplantation and are at high risk of relapse, today we are still considering transplant, because we have more confidence still of the long-term effects of a successful bone marrow transplantation. So we would need randomized trials even to compare, when we have an extremely promising drug, to be able to understand whether bone marrow transplantation can be avoided in some patients. But still today, high-risk patients, high risk of relapse, and eligible for transplant should still go for transplantation.
And could you just remind us which groups would be considered at the highest risk of relapse?
Well, if you look at the European Leukemia Net classification, a FLT3 mutation, high risk cytogenetics, younger patients should go for transplantation. Of course, now the question is, what about the FLT3 inhibitor? Well, it can accompany maintenance after bone marrow transplantation to prevent relapse. So we don't want to eliminate transplant. We want to accompany maintenance after bone marrow transplantation with specific gene targets.
Thank you. So a question that'll be interesting for our discussion on the kind of later, but how do HTA bodies, how are they likely to relate to combinations?
How do what? Sorry?
How are health technology bodies and payers in different countries likely to relate to combinations of 2 or 3 drugs? What's that going to look like from a cost perspective?
Well, I understand that the world differs incredibly from continent to continent, but any drug that can be given at home, so oral combinations, and that can give a high remission rate, will keep costs of AML down due to hospitalization and complications. So if that is taken into account, and if it is evaluated by companies and in clinical trials, meaning the economic impact of combination versus non-combination, so seeing where you can save the money by giving higher costing drug combinations, I think that there is certainly an advantage. Whether, even if the cost of the drug combination is higher than one single agent alone, it's just avoiding hospitalizations and complications and the treatment of complications that will make an economical difference.
And obviously, quality of life is a particular area of interest for yours, yes, being on the EHA's scientific working
right.
group. What research has been going on in terms of the new treatments coming through for AML, and particularly combinations of new treatments, to understand quality of life impacts?
Well, I think that it's not being included in the phase 1 trials, meaning the initial testing of the drugs. The CC486 maintenance trial reported on quality of life. And I was able to tell you that taking CC486 in the long term did not impact negatively on patients' lives, keeping them on complete remission with the drug. I think that, and I don't only think that, even the regulatory agencies require that any clinical trial ready to perform phase 2 and phase 3 studies must include quality of life data, because whatever the benefit of treatment has to be meaningful for patients. It has to be meaningful for an aspect in their life that patients would like to improve, want not to get worse, or at least remain stable. And it has to be important in their daily lives. And this can only be captured by patient-reported outcomes, by quality of life and symptom data collected from patients. And a lot of drugs are now being evaluated by regulatory agencies, FDA and EMA, based on patient-reported outcome assessment. So it's warranted in every trial, and now the companies are obliged to incorporate quality of life and symptom tools in their clinical trials. And I think that patients should be involved at the design of the trial to make sure that the tool that is used to pick up their quality of life and symptoms be appropriate to their disease and the treatment being offered.
And do you see enough good quality of life data being collected, or is the data you're getting from trials at the moment difficult to interpret?
Well, let's say that I have some criticism sometimes on the tools that have been chosen that are not sometimes appropriate to pick up the specific features of the disease or even of the drug, so that the trial data sometimes will not capture benefit, or sometimes not capture the poor part of the trial, meaning treatment adverse events taken from a patient's point of view. And I have many examples on that. And in the post-marketing, this can be picked up after, you know, when physicians understand whether physicians or even a survey like yours can pick up information on what treatment is acceptable and is improving quality of life and what is associated with a negative impact on patients' lives.
Thank you. And so a specific question we've got here around multiple agents being approved, and there seem to be certain risks of them due to interactions with antifungals, and
Yes.
the necessary antifungal prophylaxis seems to be
Yes.
questionable. What do you think
Well,
about
yes.
this?
So the point is that, for instance, you know, venetoclax, just to give you an example, you can reduce the drug dosage by a certain appropriate percentage to be able to give the antifungal agent. The physician is trained to know which antifungals can be used and how to appropriately reduce treatment dosing in order to not confer high toxicity to patients. So there is a training on that. Physicians know how to do it, and it's not going to give any problems with treating patients, even with antifungal treatments. It's actually saving some money on the drugs since we're reducing the dose.
And a question here around MDS patients who progress to AML. Many have a DNA repair defect, and also some kind of questions around APR246 activity in these patients. Is there fewer MDS patients likely to transform to AML?
Well, the TP53 gene is such a bad guy. The MDS with del5q, with deletion 5q, normally is a good myelodysplastic syndrome, but if they harbor the TP53, they have a higher probability of progressing. And then any patient with a TP53 with MDS will probably progress. And APR might have a role. We still, like I said, the trial data is not sufficient yet. And there are also other TP53 drugs being tested. So we will need to wait to see what advantage we can have. These patients even have a poor outcome, you know, with bone marrow transplantation, with early relapse.
Thank you. And I think this is the last question. AML FLT3 ITD prognosis with NMP1. What current investigations are ongoing around that? Well,
FLT3 should be used for the FLT3 inhibitors should be used if a patient has FLT3. So forget the NPM, the FLT3 mutation should be treated.
Okay. Thank you very much, Esther. Thank you for all the really interesting presentations and all of the difficult questions. A pleasure to have you with us, and thank you very much.
Thank you for this opportunity. It's always wonderful to work with all of you.